Good afternoon, everyone, or good morning, depending on where you are in the country. This is Marcy Nielsen. I'm the President and CEO at the Patient-Centered Primary Care Collaborative, and you are joining our July national briefing, where we're going to be discussing the impact that Macra has on solo and small practices, in particular primary care practices. I think many of you may have joined us last month when I went into some detail about Macra, what it is, what it means, kind of 60,000-foot view. We outlined several of our concerns at that time about the proposed rule that CMS shared and that asked for our comments on. One of the 6 items that we flagged in our comment letter and in an advocacy agenda that we are profiling with our executive membership is really around how Macra impacts solo and small practices. CMS included a number of provisions that were meant to protect small and solo practices as they tried to make this pretty big leap to payment reform and advanced payment models. But there are still some, what we would argue, improvements to be made. And today we will have a guest, Travis Broome from Aledade, will be talking with us about a similar set of concerns specifically focused on those small practices. As many of you know, we begin our presentation with just a few announcements and housekeeping items. As you can see from the webinar software that you have, we'll be interested in getting your questions throughout Travis's presentation. If you can ask them to us in writing using the drop-down question box that's provided on your screen, and then the last 15 minutes or so of the webinar, we'll open it up for Q&A. I'll share some of those questions with Travis. As many of you know, we provide these slides as a recorded presentation on our website. We try to get it up within the next 24 hours. In terms of PCPCC announcements, we've been talking about Macra for many, many months now, and we point you toward some of the materials that we've been providing on our website to include the comment letter I mentioned earlier, as well as 2 national briefing webinars on the topic, our press release. Many of these items and policy issues will be discussed at our 2016 annual fall conference, which is November 9th through the 11th. It's specifically that the full-day conference is on November 10th. This is also our 10-year anniversary. So we will be discussing Macra, its implications. At that point, we may, in fact, even have a final proposed rule. We will very likely have a new U.S. president, assuming we don't have a replay of the Bush-Gore debate, and so there will be plenty to discuss about public policy and what we see as the path moving forward. And as always, for those of you who are interested in joining the PCPCC in a leadership role, we are anxious to grow our executive membership and our influence around Macra, around payment reform, around all the issues that impact advanced primary care. There will be no national briefing next month, so everyone is taking an August recess. And without further ado, I'm going to introduce Travis and ask him to tell us about what they anticipate to be some challenges that fellow and small practices are going to run across as Macra in the proposed rule is currently outlined. As some of you know Travis, he has an MBA and an MPH, and he leads Aledade's policy efforts in both Medicare and the commercial space to ensure a viable financial model for ACOs and population health. He comes out of CMS and served as a regional manager at CMS in their Dallas regional office, and there he worked in 5 different states, focusing on Parts A and B of Medicare, EHRs, ACOs, etc. Travis got his Master's of Public Health and Business Administration and Healthcare Organization from the University of Alabama at Birmingham, and we are so pleased to have him with us. His boss was at a conference that we had, the Medical Home Summit, maybe about 6 weeks ago, early part of June. So Farzad Mostachari, of course, being the CEO at Aledade, and Farzad recommended Travis join us today. So with that, Travis, tell us about the policy implications of Macra as you see them outlined in some of your recommendations, and then we'll open up the call at 1:45, and we'll take some Q&A from the audience.
Great, thank you very much, Marcy, for that introduction. Yeah, Aledade really focus on the smaller physician practice. Our average practice size is between 3 and 4 physicians of who we work with. So that's the lens today that we're going to look through on navigating Macra through those small and solo practice lenses. And we really talk 3 goals, really. What is Macra? Kind of give us all the same grounding for what it is. And some of you on the call might be intimately familiar with it and give this part of the presentation yourself, and others might be still trying to put your arms around what is Macra. So we'll quickly give everybody the same baseline, and then we'll talk about how it specifically affects payments and reporting and decisions for small and solo practitioners, and then finally what it means thinking long-term strategically for your practice in the future. So definition, hopefully everybody knows that it killed the doc fix, so we don't have to go through that wonderful annual ritual of, everybody knows they're going to do it, but when are they going to do it? That is out there. But what it replaces it with is a very, very modest baseline increase to Medicare payments, nowhere close to keeping with inflation. So while, yes, no more threats of 20% cuts and things like we saw with SGR, it also sets up a situation where, by design, Part B physician fee schedule payments are not designed to keep up with inflation. They're designed at the baseline to be below inflation. And we'll talk about, obviously, that's where we're really going to focus in on what it means for small and solo practices in that next 10 years. Consolidate several programs into one. We get actually we don't even get fewer acronyms. So this is a consolidation. I don't work there anymore, so I don't have to be as PC. The consolidation, almost in name only, as you'll see in a little bit. These programs still exist in various forms. You just get one score for all of them, as opposed to different scores for different ones before. And then it creates a completely new path that we'll talk briefly about, called advanced alternative payment models, where you leave, where it's a true branching, where it's true, Medicare is going to look completely different for you if you are in an advanced alternative payment model than if you do Mips. So this is just a little before and after Macra. Macra affects payments in 2019, but it could be scored, starting to score and affect your reporting as soon as January 1st of this upcoming year. As Marcy mentioned, expect a final rule in late October, early November. That will give us all of the details, one of which maybe they'll delay it, but if they don't, we're talking January 1st, 2017 for reporting. So you can see here on this slide, we've talked about most of these things, consolidation of programs that we'll get into more and more, and getting rid of SGR. So there are 2 tracks, and this is probably, it feels hard. It's always been difficult for me to convey how different this is, because a lot of folks don't realize right now that they are in an and situation. Right now, many physicians, they're all being graded right now in the value-based modifier, which is today's version of Mips. And then they can choose to be in comprehensive primary care plus. They can choose to be in an ACL. They can choose to participate in a bundle payment. They might be in a comprehensive joint replacement mandatory bundle, or some of the new ones that were announced. But it's always an and factor. Macra changes that and word to an or word. So in the future, you're going to be in Mips, the future state of value-based drives, and we'll spend most of our time talking about, because that's where most small and smaller practices will be in for at least the first years, as you can see on the slide, 95% going that way, or it's a split in the road now, or you'll be in an advanced alternative payment model, at which point you are no longer in Mips, or in today's equivalent, it would be, I'm no longer in the value-based modifier, I'm in ACO. So that is one of those changes that's kind of behind the scenes, and it's tough to overemphasize because providers don't really feel it today. Physicians don't really feel the and piece very well, and changing to an or potentially has a big deal because it could make your life a lot simpler in either side. And a little slide factor, there you go. The visual that describes the two split paths there. Quick timeline. I'm obviously not going to read all of this to you. The slides will be there for reference. We already mentioned, the proposal is the very familiar, measure you on a full year, CMS gets a year, tally the results, give you report cards, all that fun stuff, and then it affects payments 2 years, so 2019. So that 2-year lag is what they propose. Certainly they've been making lots of noise recently about trying to do something about that. But there are some practical constraints to them shortening up that we'll talk a little bit about in Mips too. So Mips is the track one. It is the 95%. It's the default track. If it's kind of if you don't do anything, if you just continue to accept Medicare, you will be in Mips most likely. Combines those 3 programs we mentioned: quality reporting, EHR use, and a new category called practice improvement measures, all into one score, and then they pay you up and down based on fee-for-service backgrounds based on that score. I'm going to talk about exactly how much. These are the programs coming together. Meaningful use goes away entirely. So that's the one that really changes. There's no more incentive dollars for meaningful use on the Medicare side, and no more penalties starting in 2019 for meaningful use, actually in either PQRS, value-based modifier, quality, and then the modifier itself being the payment effect. So who's it going to affect? Like I said, nearly everyone. There are no small size exceptions. There's no proposal to phase it in over time like there was with the value-based modifier, starting with large practices and going forward. As proposed, it fits nearly every physician in Medicare Part B on January 1st, 2017. The only exceptions are our new Medicare physicians, so the people who haven't been in Medicare long enough to have a score. Really low volume Medicare physicians, as you can see, less than 10,000, not too many. And then, of course, back to my or statement, you go the or path of someone who's in an advanced alternative payment model. So most people, certainly in the first few years, are going to be in Mips. So what does Mips do to your money, as it were? Like I said, you have those very modest baseline increases, 0.5% leading up to 2019, flat for a few years, and then 0.25%. Again, obviously not keeping up with inflation. So when I'm looking at my business, how do I keep paying my staff competitive wages? How do I keep my door open as a small practice? I really need to succeed in Mips. I need to be able to, or succeed in an advanced alternative payment model if I go that way. And what does success look like? Well, there's the baseline piece of in 2019, plus or minus 4%, graded on a normal curve, right? The guy who ever got the average or median, they haven't decided which score, is going to be at 0, and everybody else is going to be on one side of the curve or other. And this is exactly how it sounds. If Medicare was going to pay you $100 and you're at plus 4%, they'll pay you $104. If you're at minus 4%, they'll pay you $96. And as you can see, that spread grows significantly over time. There is an exceptional bonus payment. This is basically Congress kind of lightening the load a little bit for physicians as they go through this. It's in the proposed rule. They say they expect the top quartile or the top 25% of folks to get this. It could be up to an additional 10% for a limited time there. That's the money. You can kind of see the same idea graphed out here of, you can see how big the spread can grow in just a few years. So, with maximum exceptional bonus, maximum Mips incentive, you can see that $100,000 is all the way up to 120, getting somewhere between 115 and 120, whereas the penalties keep it lower down. So this is a big spread we're talking about. So when you're thinking about keeping up with the future, doing well in Mips or doing well in the UPM is really key to being in a small practice. So now we'll talk a little bit more about what Mips looks like from that angle. As I mentioned, Mips is a consolidation. So what they did was they consolidated the score. They didn't necessarily consolidate the programs themselves. And this is going to be a particularly daunting thing for small practices, primarily because, if anything, reporting got harder. And there's a table, an infamous table that my boss actually Dr. Mssp that Mercy mentioned, that kind of single-handedly made infamous when he found it, called Table 64 in the reg. It actually predicts that small practices will not do well on Mips, and that Mips will result in a transfer of funds from small practices to large practices. And once that was kind of highlighted and everything, people went to the analyst and basically asked, why did you think that? And it wasn't that he thought small practices had worse quality. He thought that small practices would not be able to handle the reporting requirements, that they simply would not be able to get the information in as successfully as large organizations. So that is the biggest challenge that a small practice, and certainly a solo practice, is going to face under Mips, is not necessarily having high quality, but being able to do 3 different reporting mechanisms every year consistently and well. And as you can see, the spreads here across the score of weighting with quality, 50% clinical practice improvement activity. These are the new guys on the block, things like same-day scheduling, care plans for high-risk patients, advancing care information. If you are familiar with Meaningful Use, you'll be very familiar with advancing care information. I think they basically decided the brand of Meaningful Use was tainted and came up with a new brand for it. And then resource use, CMS's way of saying cost when they don't want to say cost. So a little bit more about what these actually are, these categories actually are. So you're increasing the number for small practices. Right now in the PQS, they went to 3 measures, going up to 6, but all of the submission methods remain the same. So if you used your EHR before, you can use your EHR now and you get bonus points. So the only difference is you have to select, again, more measures, one of which must be an outcome measure. GPRO is really only available to the larger practices. So if you're a small practice, solo practice, without an EHR, you're either doing a registry or a claim-based submission. If you have an EHR, most likely you're doing EHR submission at this point for this piece. Clinical practice improvement, as I mentioned, the new guy on the block. To get full credit here, you're going to need to do between 3 and 6 of these things. Why on earth they made the scoring so complicated for this one, I don't know, but to do 6 10 weighted points or 3 20 weighted points or some combination thereof, and to get to your total of 60 points. Unlike quality, this one is not graded on a curve. In theory, every practice in the country could get 60 points on this. Oh, sorry about that. See if I can make that go away. There you go. So this one is, you got to have the activities. Got to be doing some of the activities. That's the purpose of it. But after that, it becomes that compliance level thing of getting in the attestation. It seems like it's going to be the Meaningful Use style attestation. You go to some website, you attest to doing certain ones, and there you go. The new meaningful use, advancing care information. Like I said, if you're familiar with meaningful use, the measures themselves will look very familiar, which is why I didn't try and stick them on the slab. E-prescribing, sharing electronic health records at transitions of care, closing referral loops, medication reconciliation, making patient information available on a portal. What changed is something that folks have been asking for meaningful use for a long time, and to not be a one-size-fits-all. You either are a meaningful user or you're not, with a bright line. So they created this scoring system here, 50 points for just basically turning everything on out of 100, and then 80 possible points for performance on 8 measures. They kept it pretty simple here. There's 8 measures. They're 10 points apiece. If you scored 40% on, transition summary of care, electronic summary of care, transitions of care, you get 4 points. Obviously, they don't expect everybody, all patients, to access their patient portal all the time at 100% rate, which is why you don't need all 80 points to get the maximum score. And then they threw in this one bonus point for reporting to a public health registry. Attestation, again, just like you do for meaningful use today, you'll do like meaningful use tomorrow. They're trying to explore EHR registry type submissions. Don't hold your breath. So right now going to the website. So all of this stuff is the exact same thing, with the exception of you can't do the G-Pro if you're a small and solo practice. Whether you are a practice with 100 and physicians and lots of staff, and you actually have a meaningful use person, right? You certainly met many large clinics that have somebody dedicated to doing meaningful use. Small and solo practitioners, you essentially end up with the same requirements, but having to do everything that a larger group does. Again, just kind of a specific Mips timeline here. I won't walk you through that in the interest of time, but it'll be a good reference for you later. This is that table 64 I mentioned, where you see that solo and small practices, much, much, much higher estimated impacts on theirs. Again, because of the burden of the reporting requirements. Sorry. So now we've kind of set up Mips, and hopefully we'll have the same background on what it is. Now we're really going to look at it through the lens of that small practice. So my Medicare payments are at risk. A growing share of your Medicare payments are at risk in some fashion. Now, by 2022, I won't have kept up with inflation, and they might be cutting me 9% if I can't get their reports in. Your quality and cost performance are led to penalties or incentives. I'm graded against everybody else on a curve. You have to report these things. You have to do the compliance effort of reporting, because if you don't report at all, that gives you the max. Put you at the bottom before. So you really have to look at, do I have an EHR or not? Does my EHR vendor already help me with quality reporting? Where am I at? And really, when you're a small practice, the real decision you're going to make is, do I go it completely alone, or do I join up in some fashion with other folks? And we're going to talk, there are many different fashions that one can join up while maintaining your independence. And then there's obviously the selling the practice option. That one's kind of self-explanatory, so we'll talk about that one. But there are several options to kind of join up and maintain your protection. The first being participating in an alternative payment model. That's not necessarily an advanced one. You saw on an earlier slide I mentioned that there's special reporting requirements for Mssp, Medicare Shared Savings Program. Macra also created something called virtual groups, which by their very definition were made to allow practices of 10 physicians or less, or 9 physicians or less, to group together in a virtual way, but consolidating their practices, not taking down their shingles, but group together in a virtual way to make reporting easier. And then, of course, there is always the going alone. aspect, where you continue to do full independence on your reporting as well as the practice of medicines. The other thing to keep in mind for the future before we kind of walk through each of those three decisions is that Mips is not going to be the last change to Medicare. I'm sure most of you on this call have seen all of the scary charts as the baby boomers move into Medicare and start to use healthcare in a serious way. That wave is going to have to be dealt with one of two ways. I think right now physicians and other healthcare providers have the opportunity to increase value in healthcare on their own in preparation for that wave, or if we don't manage to pull that off over the next decade or so, then government and Medicare and payers will do the only thing they know how to do, which the only thing they know that absolutely works, which is to cut rates. So when you're thinking about this, well, we're going to focus in on Mips because that's 2017, that's tomorrow. You always want to be looking beyond Mips, beyond 2017, to the future of, I expect this practice to be independent and available in the year 2025, 2026, 10 years from now. What are the decisions that I make today going to do? So group option one is to go into an alternative payment model. Right now, the most popular one far and away is the Medicare Shared Savings Program, ACO. So this is one way that independent practices can group up and come together and pool resources and do well not only in their Mips but also in the ACO itself. The advantages for practices in Mssp Track 1, so the ACO's quality reporting counts as your quality reporting. They get 30 points automatically for being in an APM, be it Mssp or other APMs. In advancing care information, there's no direct requirements. There's no CMS given advantages. But then there's the advantage of the communities. And both the ACO here and the next thing we'll talk about in virtual groups, that's something, in my experience, having been out of CMS for 2 years and watching independent practices come together, that's something that simply can't be undervalued, is having a group of like fellow travelers, if you will, in other physicians in your area to bounce ideas off of, to know whether a score is good, right? It's one of the things we walk around a little bit in the dark on sometimes of, well, this is my EHR is telling me that I did X, but is that actually good or not? How does that compare to my peers? And that is the advantages in Mips for being in an ACO. Obviously, an ACO gives you access to claims data, gives you access to shared savings if you achieve them, but all of those things aren't dependent on Macra at all, so we're not going to cover those today. These are the advantages of coming together in an ACO under Mips. Virtual groups, so starting off with the bad news there right in the title. What Congress did is they wanted individual physicians, NPs, PAs, or group practices of not more than, the number got lost there, 9 physicians or NPs can elect to come together in a virtual group for the sole purposes of Mips. So this virtual group, unlike an ACO, is not also trying to achieve shared savings. The whole point of the virtual group is to come together as individual practices to do well in Mips. CMS was in the proposed rule said they were unable to operationalize the virtual groups in time for the 2017 reporting period. They didn't propose either governance or operation in the proposed rule. I think, I was at CMS for 7 years. I can see how this would be very difficult for them to operationalize in time. It didn't make sense that they didn't at least propose what the governance of these things would do so that small practices could kind of see what they would look like when they're making their decisions for January 1st, 2017. Myself, others, many folks have had conversations with CMS, and I think that there is a good possibility that they will try and tackle the governance part in the final rule that comes out in November. So you might not know what a virtual group, you might not be able to join one, but at least you would know what it is when you're making your decisions for January 1st, 2017. Some of the benefits of a virtual group here, eliminating small number issues and quality measures. A lot of times a single physician might have so few folks in the denominator that it's just not a reliable measure of their quality, but yet they're graded and it affects their payments. Pulling strategic resources like data infrastructure creates that accountable community for performance that I was talking about on the previous slide, but doesn't require the population health work of an alternative payment model. Doesn't require all the structure, doesn't require all the extra work and different focuses that doing an alternative payment model does. And then there's the final group, going alone. And by far the most attractive thing to the physicians who do this is that self-reliance piece. Your score is your score alone. You're not dependent on others. You don't get help from others, but you're not dependent on them either. And that is very attractive to many physicians. And there also are some opportunities that are available at the individual practice level as well that are alternative payment models like Comprehensive Primary Care Plus. On the commercial side, you see PCMH, medical home things all of the time. So it's not like there's no opportunities even if you maintain your small practice as well. All right. So I'm going to spend a lot less time and then open it up for questions on that track 2, on that 4 situation of an advanced alternative payment model and whether that could make sense or would make sense for a small practice. So quick reminder about what it is. It's 3 things. They got to have an EHR. They got to report quality through the program. And most importantly, they got to bear financial risk in excess of a nominal amount. Question CMS had to answer: what is certified EHR? How do you use certified EHR technology? What makes measures comparable to measures under Mips? What is financial risk? How much financial risk is in excess of the amount? And then the easiest one of all is: what is a medical home model expanded under section of the law? There aren't any yet, so that was easy. There are none for that one. They kept it pretty simple on EHR and measures. They basically said certified EHR technology is certified EHR technology. It is what it is. What qualifies as use of it is whatever alternative payment model structure you're in, bundle, ACL, whatever it is, whatever they say use is, that's what use is. Quality measures, again, they said whatever quality measures your program uses, those are comparable to Mips. There are a few alternative payment models that didn't require the use of certified technology or didn't have quality measures. BCPI was one, but those models are rapidly being updated to include these elements. So really it all boils down to what is financial risk. And there are several different types of financial risk. Again, these slides are mainly for your reference. But at its most basic, financial risk is if I wasn't in the model, if I was unsuccessful in the model, I'll get less money from Medicare than if I had not been in the model at all. That could come in, they'll pay me less for services. That could come in, or they won't pay for services they would have paid for outside of the model. It could come from them paying me less for services, which is this one here. And then it could come from I have to write CMS a check, which is the final financial risk. How much is more than nominal? This is where it gets really, really, really sticky for small practices. Because most of the models are based on total cost of care. Most small practices or primary care or even the specialty ones represent a very, very small sliver of that total cost of care. So even though you're seeing small numbers here, 4%, 30% of losses on 4% losses, that again is on total cost of care. So if you only represent 2% of the total cost of care from your revenue, and you're potentially at risk for 4% of the total cost of care, even though the number's small, it's 2 extra revenue. That becomes untenable for small practices. Just a quick review of what's going on, and, where all the models fell. You can see two-sided risk Medicare shared savings models, yes. Bundle payment, no, because of no EHR. Comprehensive joint replacement, no, because of no EHR. They're fixing both of those things. Comprehensive primary care, yes, and comprehensive ESRD. So one of the things we've been talking to CMS, and CMS has been very receptive to and has even included a detailed discussion in the proposed rule, is what do we do about that problem I brought up when we were talking about risk? What do we do about the fact that even 4% of total cost of care for small practices or for primary care only practices or for a single specialty represents essentially all of their Medicare revenue. And what was proposed for the CP Comprehensive Primary Care Plus program, and what we think is also would be good for all of the financial risk, is not to base it on total cost of care, but to base it on 15% of Medicare revenue. What numbers right here, NACA, everybody's got a different number here. Ours was just 15%. But the basic core principle is rather than total cost of care, base it on a percentage of revenue received by the practice. That way it is risky no matter what size you are. And that is really the absolute key to a small practice looking at whether they should participate in an advanced alternative payment model. What is the risk? Certainly there are larger organizations out there that will offer to protect small practices from the risk. But if a group of small practices is going to come together and do an advanced alternative payment model on their own, not with an Aledade, not with, Premier, not with any of the organizations do that. If they're going to do it on their own, that risk change is really, really critical to them, and hopefully we'll see that come to pass. Right now, I couldn't recommend a group of small doctors coming together and taking the kind of risk as it is today for an advanced alternative payment model. Most of you on the call are probably familiar with this. You get a little bit higher bump in your out years on the physician fee. You remember from the previous slide way back, it was 0.25% for Mips, it's 0.75% for folks in APM. And then since you don't get that Mips payment, you get a 5% lump sum bonus on your Medicare payments. And what should be here on number 3, you don't have to do Mips. Again, unlike the current state where it's an and, it becomes an or, and you no longer have to do Mips. Quick little graph kind of shows you how this stuff adds up over time. So the green line is inflation. The blue line is Mips, with the arrow bars representing how much the payment can vary over time, and then the orange line is what you get in an alternative payment model. So as you can see, nothing keeps up with inflation over the long run, but the better you do under Mips, or the closer, the longer you stay there. And then if you're in an alternative payment model, the way you're closing that gap is by succeeding in that alternative payment model. So deciding on participating in any APM, I kind of said with today's risk, I would, the bottom line here is I personally wouldn't recommend it without some kind of partner, but hopefully, and CMS has been very receptive to this, I'm hoping the risk will change and that will change so that you can do, when you look on number 3 with the partnership piece, you won't need that risk mitigation offered by the partner. CMS will take care of that for you. But as it is today, is your practice ready? Familiarity with EHR records and technology, openness to change, all of these things, most of these things grade themselves on how did you do last year. So if you're not willing to change, you can't get better next year and you wouldn't succeed in an APM. You do get the bonus payments, access to total cost of care, episodic of care. So when you take that call that prevents that emergency visit at 8 p.m. at night, you have access to the savings that generates. And then looking at the partnerships, and you're looking at whether it's other small practices coming together on their own, whether it's small practices coming together with a larger partner, whether however that partnership looks for that small practice. What are the resources and expertise coming together from those partnerships? What's the financial arrangement of the partnerships? Risk mitigation, assuming CMS doesn't take care of this for us, offered by the partners. And who your fellow practices are. That is the biggest thing. It's one of the main reasons docs remain in solo practice and small practice is because of that self-reliance factor. So if you're going to get into a group, be it an advanced alternative payment model, be it a regular alternative payment model, be it a virtual group, who's going on that journey with you is certainly one of the most important pieces. All right, and that brings us just through a couple of extra slides in here just for reference on what the existing program is and some additional resources. That brings us just to questions. Hopefully it provoked a few of them from you, and I look forward to taking your questions.
Travis, thank you so very much. This was a very nice review, both some things that we've discussed in the past, but also you've taught us a number of things in your presentation, and so wanna be certain to thank you for that and remind everybody on the call. We're getting a couple of questions about whether these slides will be available, and we'll have them up in about the next 24 hours. There are a couple of points to clarify, and we've been trying to do this as we've been talking about Macra. Macra is, of course, more than just physicians. This includes all eligible clinicians, so nurse practitioners and PAs, and some possibility for expansion to other kinds of health professionals in the out years. But if without putting you on the spot, Travis, you mentioned that the defining nominal risk is a little tricky, and I recognize that this phone call is being recorded for all posterity. But can you talk a little bit more about Aledade's perspective on defining nominal risk, and whether you have any thoughts about how medical home was to be treated in the statute from the perspective of many of us working on Macra. Our perspective was that medical homes actually would not be subject to any nominal risk standard, and we're really pushing back on that. Is that a view that Aledade shares? And if not, can you talk a little bit more about what you consider to be an appropriate nominal risk for medical homes?
Yeah, and I'll go ahead and warn everybody and give you permission, Marcy, to cut me off because you're going to. You inadvertently put me on one of my soapboxes.
Perfect.
The nominal, when we think about financial risk, and this is really more Aledade coming from, our work on previous now, and really our belief that independent practices represent one of the best ways to deliver care and going forward. So a lot of times at Aledade we talk about, we know what we believe is best for nominal risk, and for our practices we'll put what we kind of term an Aledade wrapper. Whatever CMS comes up with, we'll just put an Aledade wrapper using our resources and know-how and just make it what we want it to be. But we want it to be available for everybody. And the thing that I view risk as, and I think Congress, by making it more than nominal, which translates into more than very small an amount, was on board with this too. I had a chance to talk to Karen Fisher, who's one of the people in the Senate, and she said this made perfect sense to her that risk in a two-sided model, because these are all voluntary right now. So the idea that some folks occasionally have that some organization is going to pay back losses for like 3 or 4 years is just silly. Like the purpose of two-sided risk is not to get money back to the Treasury or get money back to Blue Cross Blue Shield if we're talking commercials or whatever, because that's just not going to happen. Providers will just drop out of the program after 1 or 2 years of losses. The purpose of two-sided risk is to make savings more likely. It's not to generate, it's not to make losses. It's to provide some behavioral economic motivation to make savings more likely. And we think with that purpose in mind, the savings really should always be more than nominal for everyone who receives them. That's why we really focus in on the revenue side of, we want it to be motivating, but we never want it to be existential. We never want physicians, be they small practices, be they large practices, be they integrated delivery networks, never want them looking at a situation where one statistical fluke of a year could end their business, could end their practices. And for IDNs, the current models wouldn't do that. But for small practices, even though it's incredibly unlikely, there is that possibility that's an existential threat. And we just don't think that's helpful, right? You don't play chess better when a gun's to your head,
So oh dear, you are working with Farzad. That sounds like something he would say.
Yeah. So that is absolutely where we are on that. When it comes to the medical home piece, I think it was very clear in the legislation that for models that have been expanded, that numbers translates into CMMI, that they were to be basically models that have proven to save money, which is what you need to do to be expanded, would be exempt from the nominal financial risk standpoint. And CMS doesn't currently have a model that does that. So what they did instead was they took their one model that's trying to do that right now, the Comprehensive Primary Care Plus, and did some rather impressive regulatory gymnastics to create a much less risky situation for that model. So while it technically still has some risk, the risk is that money CMS gives you for being in the model, they might take it back, right? So that's certainly no existential threat to the practices. So I think CMS tried to monkey around the law as best they could. I think probably the biggest thing they could do is, as far as pushing the medical home piece and for small practices who want to, especially those who are interested in going the loan route, is to do more experiments, to have more options than just the one that may or may not come to their town today. And they probably couldn't afford to do a comprehensive primary care plus style thing across the whole country, but a lighter touch model that was nationwide, as opposed to just the small, the few markets that comprehensive primary care plus will be in.
Yeah, it is going to be very interesting to see how they respond to comments and whether they're going to be able to make changes in the final rule. I've got a couple other questions here for you, Travis, that I want to make sure I get to. Can you talk a little bit about the special considerations for rural health centers and SQHCs? They, of course, are cut out from participation based on the way in which they are reimbursed. But given all the work that Aledade does with small practices, and maybe you all work with SQHCs and rural health centers as well, you may have some additional insight to offer there.
Yeah, we have both in our ACOs. We have one ACO that is actually all SQHCs. And I kind of went to them and asked and said that, you guys are cut out. How do you feel about that? And to be perfectly honest about it, they said, we're fine with being cut out because Medicare isn't where our action is. Where they really look to is, particularly the FQHC, is Medicaid innovation. So I think that they're a little satisfied with not having to bother with a Medicare-only program, where what they really want to see is the stuff CMS kind of punted down the road a little bit when you talk, that I didn't cover in their presentation, about when you move beyond just Medicare and you start to include Medicaid and commercials as well. RHCs certainly have a bigger Medicare book of business. I think so they tend to be a little more diverse in their opinions about whether this was a good thing or a bad thing for them to be left out. You know, kind of what we tell them is you weren't left out of being in the alternative payment models. So when you're really, really looking to the future, that's the long-term future, so maybe not worry so much about, you know, the few years of Mips.
I do think, though, that there are some lessons to learn from patient-centered medical homes, and the fact that early on FQHCs who were doing a lot of that work, but were not getting a direct reimbursement because they don't largely, or didn't previously, largely get commercial insurance reimbursement, and so they didn't really get in the game early on around PCMH certification, and then when they did, there was a fair amount of catching up to do. So I always worry a little bit when based on their, you know, means to be reimbursed through HRSA, that they're not included with everybody else, because at some point they will be, and then they're racing to catch up. And of course, they have a very special patient population that they are trying to take care of, and they were, in my opinion, significantly underfunded as PCMHs when the federal demonstration project focused solely on FQHCs, and so their outcomes looked unfortunately not great compared to some of the results that we've seen in the Comprehensive Primary Care Initiative or the multi-payer advanced primary care initiative. So you'll fix all that since you've got all these folks that Aledade works with, right, Travis?
Absolutely. Yep. And yeah, I think one of the things we've seen, and I think it speaks to your point well with the FQHCs in particular, is that they do very well for their target population, which is basically duals. The benchmark for dual population in our FQHCs is just absurdly low. They're salivating to the day when they move to regional benchmarking. But that's been their focus for 20 years. And like you said, if more things come their way, they can't be as myopic anymore.
Yeah. So another terrific question that we're getting is for those small and solo practices that really aren't very experienced with EHR technology, Macra does allow some exemptions, but what would you recommend, because ultimately they're going to be held accountable for the ACI category, which replaces meaningful use, and what do you think they ought to be focused on now to get prepared for Mips?
Yeah, I mean, if you're still in the situation where you're looking at, you know, whether to adopt EHR or whether to switch EHR, there's really two questions that really only one core question of, you know, how far into the future do I see my practice? You know, if I see my practice, you know, if I'm 65 and 60 years old and I only see my practice for a few more years, and there's no obvious opportunity for it to continue under a younger physician or something like that, then, you know, then waiting it out might be a viable option. But if you want your banner, right, to carry forward for 10 years, 15 years, 20 years, either under yourself or under, you know, younger partners in business, then really embracing EHR now, working with other, you know, the community thing we keep coming back to, that it's certainly been one of the delights of the work we've been doing over the last 2 years of talking to others in your local community. You don't even have to have the same EHR. You know, even if they don't have the same EHR, you know, how have you figured out how to do annual wellness visits well? And you know, chronic care management is the new code up there. Some EHRs are okay at it. Most of them are dismal. So how do you work around that and just kind of re-engaging the physicians and coming together as a community of physicians and providers to, you know, say, this is, you know, yes, it would be great if it was hand-delivered to us in perfect form from an EHR technology vendor, but, you know, that's obviously not going to happen because it never happens, and, you know, no technology is perfect. So I really think that if you got that long-term vision, just embracing it, always know it can be better and work to make it to be better and talk to people about how it can be better.
One question that does come up is that, and we're pretty overt about this, but I was wondering if you shared this opinion, Travis, which is there's a question about, are you saying the practices will prefer being an advanced APM to being in Mips? And what we say is, well, everyone has to start in Mips, but I think for most practices, they are going to want to become an advanced APM so that they can get out from under the Mips reporting and they get the 5% bonus. That could be oversimplifying things, but is that how you talk about it at Aledade?
Yeah, I mean, we certainly want folks to, you know, advanced APMs is absolutely our end game, but we want, when you're thinking about an advanced NPM, two-sided risk, 75% share rate of total cost of care, like you want to be in an advanced AAPM or advanced alternative pay level, not for the 5%. 5% is nice, I guess, but you could probably get the 5% for those years under Mips if you're good with the exceptional bonus rate. You want to be in it because you want to succeed in the AAPM.
Right.
I mean, you know, that's yeah, that slide I had where like that blue line was outpacing it, everything, even if you did awesome under Mips, that you close that gap through success in an AAPM.
I think that is a fair point, and certainly for those folks who have tried to become a patient-centered medical home and offer all of the services that come with that model of care. So many of them aren't reimbursed under fee-for-service, and that's the impetus for moving out of Mips. Mips will hold you back if you are tying all activities to a system that ultimately isn't giving you the flexibility and the freedom to offer the kind of care you want for your patients. So with that, it is the top of the hour. There are a couple of questions that, Travis, I hope that you can see we will send along to you so that you can provide answers to folks. I would like to thank you very, very much for your participation. I learned a lot, and we will have the slides up in about 24 hours. Thank you for your time. Thank you, all the participants, and stay tuned. There's going to be a lot more Macra to come in the next 6 months. Thank you, everybody.
Thank you.